So she was leaving us and one and most of the time she might but there's no I hope that she has also stayed for the rest of the session until the end. But I really know how busy it is and how much people like to meet with that. I'm really grateful to the stand for this and for the topic as we become the and equally important to bring up the representatives of several nations who are around the table on different states.
Thank you, Rajiv, and good afternoon to friends and colleagues, and I want to thank especially Farrar and Christoph for joining us, and of course, welcome to all physicians and representatives to join us for dinner, today lunch break. I mean, lunch break seminar is quite a challenge. You want to learn, you want to listen, and at the same time, you need to do. And I hope we have provided you with something very basic, and so that you don't go hungry. Let me once again say how happy I am to join you and all of that. First time I could stand with you on this very important subject. I want to thank you for joining the Global Health History Seminar on antimicrobial resistance. This is very important subject with very timely. Christoph has working with partners and countries, working ahead in this experience working. When you look at the history of antimicrobial, usually it's not the of the antibacterial properties of penicillin. Revolutionized the management of infections by many people to mark the start of ordinary. Common infections that almost invariably kill could now be cured. The benefit of his discovery and the other miracle drugs that follow are a number of projects and a matter of history. And with many millions of lives saved. Antimicrobials, together with vaccination programs to prevent common infection, led to a surge in life expectancy all around the world. These medicines also make surgery safer, supporting advances in that field as well. And another contribution to better health, the use of antimicrobials might stop improve agricultural profitability and contributed to greater food security and better nutrition. The post-pandemic era for health may be coming to an end. The widespread overuse and underuse of these fragile medicines has encouraged the development of resistant strains at an unprecedented rate. Most recently, we have seen the development of strains, sometimes called by the media, in quotes, superbugs, that are resistant to virtually all available medicines. Once again, causing infections that are difficult, if not impossible. All pathogens will eventually develop resistance. What it was there. As standard planning, Kieny recognize the potential for the development of resistant strains of bacteria and refer to these problems in his Nobel Prize selection in 1945. Refer to the problem of underdosing with penicillin, since the medicine can be bought by anyone in the shops. Today, ladies and gentlemen, we still see this happening in many parts of the world. Antibiotics are freely available as over-the-counter medicines or sold by strict centers. We have to stop the treatment costs as soon as they begin to feel better, killing only the weaker pathogens while allowing the stronger ones to survive. But in most populations today, is the accelerated rate at which drug resistance is developing. People are once again dying from previously easily treated infections, like gonorrhea and tuberculosis. Second-line medicines are much more costly and have more dangerous side effects and complications. Ladies and gentlemen, antimicrobial resistance reflects no bodies. For example, a multi-drug resistant strain of tuberculosis spreads easily in the air. As our member states stress, antimicrobial resistance threatens all countries in all regions. It is a global problem that requires everybody's urgent attention. If current trends continue, the world could move into what we call a post-antibiotic era, especially as so few new replacement products are in the pipeline. Many sophisticated treatments, such as cancer chemotherapy, hip and joint replacement, organ transplantation, and care of preterm infants would become too dangerous to undertake. When the World Health Organization, our member states unofficial develop a global action to combat antimicrobial resistance, ready for submission to next year's understanding. The next year's health understanding is the last comment. So, more specifically on developing an inclusive plan that addresses the need for capacity in all countries. We were also asked to define roles for multiple non-addressed, especially during the last voice of the past, using animal husbandry, agriculture, and aquaculture. As requested, we worked very closely with NGOs and YPs. Earlier this year, Medical Issue Report also stated of worldwide evidence for antimicrobial resistance. Those data are not available for all countries, but the overarching message was very clear. And that is the point. Antimicrobial resistance affects all countries, whether rich or poor, in all regions. As we finalize the action plan, we are following several guiding principles. First, we need a whole of society approach involving all people in all directions. Second, recommended actions must be backed by scientific evidence. Powerful economic operators have long resisted efforts to reduce non-human users of these medicines. Third, prevention of infection must be the first line of defense for reducing the use of antimicrobials. This means better personal hygiene, good hygiene, and infection control to limit the spread of infections. It means better immunization programs to prevent infection. The logic is obvious. Fewer infections reduce the need for antimicrobials. Finally, find the right balance between access and excess. In some countries, antimicrobials are overprescribed. Doctors may not have time to do that and to do a good examination and get a good history, and may hand out antimicrobials or antibiotics to the other safe side. In other countries, patients who may have traveled a long distance to reach a clinic, they want to go home without any medicines, and they ask for prescriptions of antimicrobials, putting a lot of pressure also on the doctors. Patient demand for antimicrobials has also contributed to the problem. In few other parts of the world, people continue to die, and die needlessly from lack of access to these life-saving medicines. The challenges are many and are difficult, and need to be comprehensively addressed. medicines is used, changing the behavior of people, including medical science, is one of the hardest parts facing public health. A great deal is at stake, ladies and gentlemen. The world is looking to the medical body to reverse the trend that can lead to the end of modern medicine as we know it. I'm personally fully committed to the program of work that began even before this year's resolution asking for a global action plan. And I look forward to working with all my member states and the other partners, the scientific community, civil society, professional groups, to take forward what is needed to reverse a very dangerous trend. And I'd like to recognize some of the countries here. We were very strong supporters of the antimicrobial agenda, and thank you to the Netherlands who organized the meeting in Hague. I attended, and of course the United Kingdom, Spain, Variability is taking this agenda forward, along with many other countries. And I think your support is extremely important going forward. On that, let me thank you for your presence here and Master of Police and Jeremy. Chris, thank you.
Thank you very much. We for the overview and for the direction and the commitment of the organization who have contributed on this issue with the full engagement and support of our members. Thank you so much. I really appreciate it and will appreciate the work and the wisdom. We can move to the next speaker, and it is a real honor actually for me to introduce Professor Farrar, and I knew him actually virtually a number of months ago, or less. I was reading the Financial Times, and there was a full-page interview with him, and I thought, well, that's the kind of person that would be good network, and that's the kind of person that would be an honor to know and to engage. And then, of course, looking at our relation with the good contact and the different types of engagement, I felt very pleased and honored actually to be part of that. Professor Farrar is the director of Wellcome. Before joining the staff, he was director of Oxford University in Vietnam, not in the UK, in Vietnam. So he knows that the issue where his research was diseases, and emerging infection. He has contributed to over 500 peer-reviewed papers and has served on several versions of WHO advisory committees, including two these days happening in dengue and Ebola. So it's a huge honor for us to come to this forum and to invite you to share ideas and to take on the AMR from both historical point of view and mutual point of view. Also.
Thank you very much to those very, very kind words. I apologize for finding time last week. Anyway, thank you very much for the introduction. And thank you also very much for the superb introduction from the Director General. I'm not sure, if I'm honest, that I'm going to be able to give great insights in my next 20 minutes in what we've already heard. And that is a credit to the way that this organisation is thinking about this hugely important issue. So, to give you a perspective, I am now the Director of World Trusting for the last 12 months, and the World Trust is very honoured to be able to support this series. Thank you for all the people who have made this happen. So I come here both as the Director of World Trust, but perhaps more importantly, from experience of the last 18 years, which was as an infectious disease physician, clinical scientist working in the hospital infection in Vietnam. And this was my wardrobe over about 18 years. I feel very much clinical end of clinical science, with background in infectious disease. And if you any one day of my wardrobe over the last 18 is this would be the sort of range of patients' illnesses that they had when they came in hospital. And perhaps it's worth highlighting the top one there, which will come as a surprise to some. And that is wherever you are in the world, and certainly in any developed or middle income country, the truth is that most individual patients never get the diagnosis established microbiology. We don't know the causes many people come into hospital with infectious disease. A diagnostic capacity wherever you are in the world is less good than actually face-to-face many people will assume. That's, of course, more of a problem in lower income countries. This is actually a problem everywhere. Here in Geneva, you will not establish a diagnosis in every patient coming in to the university hospital. The other, if you look through this series of patients that I would see on my wardrobe, severe respiratory infections and ventilation-associated pneumonia, severe sepsis. I was trained originally as a neurologist, so I've been interested in brain infections, tuberculosis affects the brain, meningitis, bacterial meningitis affects the brain. All of the infections associated with HIV, tuberculosis, induction, penicillin, and HIV itself, severe malaria, severe typhoid, and the complications of these other infections which might require intensive care. All of those would be affected on a regular basis by coming from antimicrobial drug resistance in different ways and in different levels. If I take one example of the infection I know very good about, TB meningitis, TB starts off mostly as a lung disease, but it spreads more commonly in those who have drug resistance. The antibiotics used are not able to control the lung infection and spread to more parts of the body. And the mortality rate from somebody with tuberculosis in most parts of the world is somewhere between 40 or 70%, depending on whether you're HIV infected. So that's the common and established toxicity. It's also true for Africa, true for India, true for southern China, true for most parts of structural and low-income countries as well. Now, I want to share with you, sometimes it's difficult to bring this down to the individual level. You see antimicrobial resistance, and in some ways I think have similar analogies to environmental change that we go through. It's very important to appreciate this is not something that's going to happen to your grandchildren. This is happening in every hospital, in every country, in every part of the world today. And we've watched and we've waited for this to become a bigger problem. But it's not going to come in 20, 30, 40, 50 years' time. This is a problem today. But this is a patient actually that I saw just 2 weeks ago in a hospital, actually, in Vietnam. A young individual, 33, everyone younger than me is young, previously fit and well. This is not just something to affect people with multiple comorbidities. And this is a hospital with fever and a cough and had a problem centers around the liver area. And these lesions, if you can see them, I hope on the scans of hyperdense lesions with this is his chart, and this was from the this could again be from any country, in fact anywhere in the world. This could easily happen here in Geneva, in New York, in London, in Paris, in Amsterdam. Came in, initially you cannot wait until you have a diagnosis established and microbiology confirmed and the antimicrobial resistance happens, because that will come back 48% so absolutely right. The patient will be dead by the time they're top through. So you have to start on something, and you do that at best guess. And if you look over the course of time, from the beginning of October until actually now the beginning of December, those patients are still in hospital. You can see how the antibiotic regime, empirically, often not directed by variability, is changed, is adapted, is modified. The fever continues, the blood culture initially through what's called the gram-negative bacteria. It has a resistance pattern, which means it is not sensitive, it could not treat with traditional antibiotics. And then over the course of that month, now 2 months in hospital, not only did we develop a very common, increasingly common bacterial resistance to all the sun therapies, but subsequently developed a humble infection. And the fever chart here, you can see, continues to go up and down. You could go to any hospital anywhere in the world, you would see exactly the same pattern. We've made unbelievable progress over the course of all of the single generation. If I go back to my mother's generation, who was brought up in the pre-cancer era, and who was attending the pre-vaccination era. It's difficult to compare with where we are today. So we have an amazing array of vaccines. We missed a large number of vaccines. We don't have very effective good vaccines to fight COVID. We are still some way off having an HIV vaccine. But nevertheless, we've made unbelievable progress across the range of infections. We've improved societies around the world, economic growth, infection control, the way the standard of living in many parts of the world as a whole to improve, and that has a major impact on the infection. And we've developed this class of drugs, as you heard, from Alexander Fleming in the 1930s and 40s. First, antibiotics coming into clinical studies and used in the 1940s. That's one generation. So my mother would be more than be brought up before my generation. And we are at a tipping point, I believe. In fact, I believe we've gone beyond that tipping point, where these class of drugs, which complement the changes of society that we've talked about, and public health, and vaccination, this cannot be seen in isolation. These all go together. We're in great danger of losing all of these classes of drugs. And as the Director General said, this is not just about the realm of infectious disease. This actually underpins the whole of modern medicine. Surgery would be incredibly difficult. The balance is whether you do a hip operation or not, or whether you do any other surgery, is the balance between the risks of doing that surgery and the benefits. Over our generation of people in this room, that balance has shifted totally in terms of where the risks are reduced and the benefits increase. And the risks will be reduced by much safer anesthetics, much safer hospital environments, much safer protection and entertainment. And antimicrobial agents have played a key role in that, either given before the surgery, during the surgery, or after the surgery, and massively reduce the risks of surgery when you undertake surgery. The same is true of chemotherapy. Almost everybody receiving chemotherapy for cancer has to have some sort of antimicrobial agent during their chemotherapy in order to protect them as you destroy or dampen down the immune response inevitably with chemotherapy. Those individuals are more prone to infection, and we have to control that. Becoming the epidemic, as people call this, of diabetes. Diabetes can be controlled with insulin and tablets, but inevitably people with diabetes are more prone to infection. These are often deep-seated, nasty ulcers where the infection gets co-infected with the Gradmann bacteria, which becomes increasingly resistant. The control of diabetes and the change that we've made in diabetes control over the last 20, 30, 40 years would also be a focus. In all of the working lives of people in this room, we've come to have HIV. HIV is a prognosis that started in the mid-1980s. It probably first emerged in humans from an animal reservoir in the 1930s. The people in the room between the ages of about 45 and 55 would have been young doctors when HIV first became a problem in the world. It was one of the most solitary times of my professional career because it was mostly young people in those days when I was a junior doctor in London. They were untreatable infections. Young people came into hospitals with secondary infections on top of the HIV, and we had no way of treating the HIV. And it was essentially an untreatable infection. That again was 30 years ago. We transformed that world with becoming an antiretroviral, but nobody should underestimate the ability of the HIV virus to adapt to move beyond the control of the antiretroviral drugs, which is essentially the underpinning of safe control mechanism for HIV. And if we were to develop HIV drug resistance, and that was able to spread, that's not practical long-term thinking. I think that is likely to occur in the working life of some people in this room. Then that would again transform the system back to an HIV untreatable era with huge knock-on consequences for everything. As the world has developed over the last 20 to 30 years, we've come to develop medications around the world. That's a good thing. They play a very important role, but they also try to spread infections can be very problematic. Again, as the world changes, ABVs look like this, increasingly around the world looks like this. Obesity is becoming a bigger problem. We have actually not worked out how to treat these individuals as microorganisms. And the doses we use today in people who are under 120 kilograms are the same doses that we use when those antibiotics or the prescribe. Also, individuals that will be unable to apply for increasing content design may respond to antibiotics the way we have to achieve the inevitable. Antimicrobial resistance, this is a very one of my favourite papers for one decade actually. It's old now from 2008. What it's demonstrated is that the world is not even, and the importance of surveillance. So if you take this is emerging infection, but which I think drug resistance has to be classed in the same category as other emerging infections. In my view, all of the emerging infections that we deal with, even through the current crisis in West Africa, the most important emerging infections in the 21st century will be drug resistance. And you can see if you're green in this, it either means there's no data, most likely, or if you're red, it means there's a high degree of chance of drug resistance and marine flu. You can see the research areas of the world. Here in Asia, largely driven by very large populations of antibiotics and pathogens extensive use in the agriculture sector. Here in Europe and North America, probably because of that development, but Europe has faced a major problem with antimicrobial resistance. All countries in Europe are not in a position in that regard, and sub-Saharan Africa continues to be a major problem, largely because of lack of good surveillance.
So if I classify antimicrobial resistance in the
context of emerging infection, and look at some of the issues on at the moment, this is in December 2014. If you look around the world, there's becoming artemisinin resistance. Artemisinin is the most important antimalarial drug discovered in the last 30 years, and artemisinin resistance developed in Southeast Asia some 6 to 7 years ago, and is now spreading eastwards and southwards. And I'll come back to resistance areas. Multi-drug resistant tuberculosis, multi-drug resistant SDR resistance, and totally drug-resistant tuberculosis is present in certain countries. If other countries you will know, and a huge attention is attracted by viruses, Ebola, and Marie-Paule disease. The type of drug resistance is present in many parts of the world. I mentioned HIV, drug resistance, bacterial infection, and even influenza is at risk of development resistance. And the drivers of this are multiple, and it's not possible to list them all, but I've chosen some here. I've chosen this one. This is the only data I'm going to show, but this is the amount of an antibiotic in your blood over a 14-hour time period in red. This is the amount of antibiotic in your blood. This is the amount of antibiotic you would need to have in your blood if you wanted to treat systemic strains. This is the amount of antibiotic you need in your blood if you want to treat a resistant strain. And our problem globally is that we're not adept enough and fast enough to change our way of prescribing between sensitive strains and resistant strains, such that we're at this level, we're not getting enough drug into the individuals. This is not an explaining in the direct general manner. On the whole, we've been too slow to adapt our treatment regimes to ensure that we're treating animals. The wide availability of antimicrobial agents is freely available across the counter with no prescription in many parts of the world is an absolute nightmare. And
factories the world over, some of them contain antimicrobial agents, some of them do not. The ones that contain 10, 20, 30% of the antimicrobial agent are even more worrying in some ways than those that have no antimicrobial agent in. This is a massive business that is linked to all sorts of other nefarious businesses around the world, but the number of counterfeit drugs in circulation globally is massive, particularly in low and middle income countries. The use of antimicrobial agents in the agricultural sector is huge, and those antibiotics are commonly shared. And lastly, sanitation and infection control. Many parts of the world still lack basic sanitation, and the prevention of infections is a hugely important part of prevention of drug resistance. This is where antibiotics are used. We may look at general practices, we may look at community use, we may look at hospitals, but the truth is 80% of all antibiotics in most parts of the world are used in animals, not in humans. And until we understand this dynamic between animal reservoir of resistance and the human reservoir, and until we try and separate these two classes of use, I think we're going to continue to have movement back and forth between these classes of drugs. And it's not just the animal sector. as defined by cows or growth promoters within animals, is also in the aquaculture. So if these are drugs used in aquaculture, growing prawns or growing seafood, whatever it is, in industrial places, in industrial scale. And yet many of the antibiotics used in the aquaculture are critically important human antibiotics. These are critically important according to WHO 2011, and many of these are freely available within the aquaculture as well as the agricultural sector. Data globally is poor, and it remains poor, and sadly it remains poor in parts of the world where, of course, the need is even greater because of the burden of infectious diseases. And if you're dark green in this map, of course, your data is probably a little bit better, although it could be even better. But if you're checked or you're light, the data available is poor from these countries. And I think we all have a responsibility to enhance the surveillance globally of antimicrobial resistance so that individual governments, as well as the World Health Organization, has that data available. This is data from 2013 from the WHO report. The impact is huge. The data, again, bearing in mind my first comment that most patients coming into hospital will not have a diagnosis. You can only define a death from a resistant bacteria if you grow that bacteria. So these are going to be underestimates. But you can see in the European Union, 25,000 deaths. In the United States, 23,000 deaths. The reality is very much more. But in Thailand alone, with only a population of 70 million, about 40,000 deaths are attributed. The burden of this will lie mostly in lower middle income countries. And the rich world has an absolute responsibility to support that, but also for narrow self-interest, because inevitably infections that do become established in lower middle income countries will come to have a direct or indirect impact sooner or later across the world. I'll go on through these quickly. We've had some massive success stories. I've talked about HIV and how we've changed that from a death sentence 20 to 30 years ago in parts of the world to a manageable infection in many parts of the world. There is still a huge amount of work to be done to ensure everybody has access to antiretroviral drugs, but we have had a huge change in dealing with that infection. Malaria is another massive positive move forward. With the coming of artemisinin combination therapies and bed nets, we've been able to save millions of lives over the last decade. That is in now grave danger of being reversed, both because of the loss of the best treatment option, artemisinin, but also because impregnated bed nets, which have had such a positive impact, will also suffer from the coming of resistance to the insecticide that impregnates those bed nets. So this goes beyond drugs themselves to other control mechanisms. I hope this will show. This shows you chloroquine resistance, just to demonstrate and put this into context. Sorry, it won't show. I don't think I can show the graph. Can you just press the return button? Apologies if this does not show, but what it demonstrates is we've known about this coming for a long time. Chloroquine was the standard treatment for malaria in the 1950s and 60s. Drug resistance became established in Southeast Asia in the 1950s, 1957, and if this map were to be shown, it would demonstrate that within a decade or more, this spread to the whole world, and chloroquine and SP, a second drug for the treatment of malaria, became essentially useless for falciparum malaria. We are facing exactly the same today in artesunate-resistant malaria. So we have a long track record of watching and observing this happening. We don't have such a good track record of acting. So go back to the slide. And this is where we are with malaria. This cliff face at the moment, this is 1975 to 2015. This is effective drugs up here. This is not effective drugs. And you can see chloroquine, SP, mefloquine, quinine, and now artemisinin resistance. We are losing these, and we don't have a strong pipeline for replacing these drugs in the future. We watched that in 2007, 2008, and one of my other messages for today is, although surveillance is important, and it is critically important, we have to have the facts. Unless as a community, and critically I believe this means the WHO, unless we learn to have surveillance and then act quickly, we will watch and we will know what's happening, but we will not impact on the movement of that issue, whether it be Ebola or drug resistance. We have to learn to combine surveillance with action. We failed in artemisinin resistance. We have not controlled it. It started in Cambodia. The epicenter for this is now the middle of Myanmar, and it is spreading towards the Indian border, and very quickly it will be in sub-Saharan Africa. But I worry there are lessons to be learned there for tuberculosis, for staphylococcal, for Klebsiella, and hugely worrying for HIV. I believe this is a turning point, and this now comes, I think, to a discussion about how global organizations, of which the World Health Organization is the leader, and I hope the Wellcome Trust will play an increasingly collaborative role with, is how to achieve the aims that we all know have to go. I won't go into all of these, but they're going to be cross-sectorial: medical, veterinary, agriculture. We've got to learn how to use what we have better, because we don't have new drugs tomorrow. We're going to have to learn how to use combinations, and we're going to have to learn how to use antibiotics, antimalarials, and antivirals in a population they were not originally designed for, whether that be obese or because of elderly populations or very young populations. We have to get better at policy and regulation. It should be unacceptable that you can buy these products over the counter without a prescription. We have to appreciate that these are going on in a complex social environment where behavior change, sanitation is critical, but also that this has massive economic consequences. And I think we have to rebuild a new relationship with industry. As an academic for 25 years, I have never developed a new drug. New drugs will come out of industry, but we have to learn to work better with industry, and there will have to be, from the public purse, an opportunity to de-risk industry. 25 years ago, there were 22 companies working in this sector. Today, there are 4. In the future, there may be only 1 or 2. We're going to have to work out how to de-risk and how to incentivize the development of new drugs, how to use new drugs in combinations, and critically, because vaccines have a critical role to play in prevention. This needs leadership and coordination, and I believe the opportunity is now for the World Health Organization to play this critical role in providing this leadership. But in doing so, it will also have to take on a more critical role. One of the great challenges of the World Health Organization is that it is a secretariat of its member states, and sometimes it will have to be critical of those member states in order to push action forward. And this is critical for all of us everywhere in the world. And I hope and would encourage the WHO to take that leadership role. Finally, we have become better at surveillance. It is not perfect, and in certain parts of the world it desperately needs to be improved, and we need to learn how to share that data more widely. But what we haven't done is learn, when we pick something up, whether it be drug resistance or Ebola, how do we act robustly, quickly, effectively to put an end to whatever is coming, whether that be a new epidemic of SARS, a new epidemic of Ebola, or the coming of drug resistance. We have to add an effector arm to our increasingly improving surveillance. Surveillance itself will not solve the problem. And with that, I'll finish. Okay.
Yes, Najib, I'd like to raise one very important point that Professor Farrar mentioned. WHO is not, afraid and shy away from taking the leadership. Our role, and this is a problem with the member states, we can sound the alert, give the evidence, and inform them of the risks. Oftentimes, our message falls on deaf ears. Now, people always talk about lessons learned. I'm arguing. Countries of the world just observe lessons. They never learn. Why? This is not the first time we sound alert. Let me be honest with you, as we are discussing Ebola now. The regional office, including KG Fukuda, is there. He did a press conference on the 8th of April to sound the alarm to the world. The media did not pick up. When you're not on CNN, BBC, nobody pay attention. And many thousands of cases of Ebola happened, and hundreds and hundreds of deaths happened, right? No, did not make a dent. Yeah, they know there's Ebola. Only when the first case arrived at USA and the whole world became at top level. Ebola was always the first media title when you Google. What went wrong? Sounding alert is okay. We do it. And in fact, you should attend some of my governing body meeting, and I'm sure the mission representatives here will tell you the DG is a strict talker. Always remind member states they did not implement the resolutions that they agreed. They always have resolutions, but the implementation gap is a big problem. Now, should we blame Minister of Health? Those are normally the ones who come and agree on the resolution. When they go home, the ministers of finance, the prime minister, or the president says that, what is this? You want money? No. This is a big challenge. I want to use this opportunity to reinforce, the important subject of antimicrobial resistance. And I see some country representatives here. Germany will take the antimicrobial resistance as a G8 top priority. Angela Merkel, I want to thank the Chancellor for doing that. And I hope you will join forces with the academics, with those of us who push this agenda item. Member states should be held accountable. If they sign up to the resolution, if they don't deliver, we need to be able to blame them. Talking about, you talk about the importance of counterfeit medicines. This organization's member states are totally divided on actions that need to be taken. So what am I saying? We are kidding ourselves. And all the important issues that need to be addressed by countries, what is a better solution to make sure countries are being held accountable for delivering what they have committed to? And this is the biggest challenge for the organization. But in the remaining 2.5 years, please use me. Thank you.
Thank you. Thank you so much, Dr. Chan. Thank you very much, Professor Farrar, for these fantastic views and points that you have shared with us. We will have time for discussion after the two presentations, so please hold your questions and comments. Now it's my sincere pleasure to introduce Dr. Marie-Paule Kieny. I know her very well over the last few years, being my Assistant Director General. And she became Assistant Director General actually in October 2010 and is now leading the cluster which is called Systems and Innovation. Before that, she directed the WHO Initiative for Vaccine Research since 2001. And before coming to WHO, she was the top research. She has the top research positions in public and private sectors in her home country, which is France, including Assistant Scientific Director in a number of places and Head of Hepatitis C Virus Molecular Virology Group at the French Institute of Health and Medical Research. And I can assure you and tell you that she is a real scientist, and it's always a pleasure to hear what she says about these issues and her leadership. And now she's doing a great job in the Ebola vaccine trials, and she's working hard. And I'm really grateful that she has also made the time to prepare and to come to the event and to share her ideas. Dr. Kieny.
Thank you very much, Najib. It's a real pleasure to have this opportunity to describe to you part of what the WHO does for antimicrobial resistance. Of course, I will not attempt to cover the whole spectrum because we do have a lot of activities, and I hope that that this will reassure Professor Farrar that we are not just observing and waiting for the AMR problem to expand even further. So. Can you give me the thing here? Merci. Okay. So indeed, an international response is required, and I think that you will have been convinced by the presentation of Jeremy. And this is indeed a request also of the member states of WHO on the Secretariat. So in May this year, we have been requested by the member state to develop a draft action plan to combat AMR and to ensure that all countries have a capacity to combat this problem. Of course, it's not a question only to say you should do it, it's a question of helping them doing it. Then we are working currently on a draft global action plan, which will be submitted to a World Health Assembly in 2015. And we have actually this action plan draft will be already discussed at the Executive Board in January. So this action plan is not only about WHO, about the health sector. This action plan wants to take an approach which is multi-sectoral, as is the problem, and wants also to consult member states as well as other stakeholders, and notably the food industry and the animal husbandry industry. So, of course, we need to base this draft global action plan on something, and we are using the data which have been accrued and published in this global report on surveillance in 2014, which has data that Jeremy has shown in his presentation. I am just reminding you the main conclusions of this report. And it makes a point that there is a high resistance in all regions to common treatment. So this is something which is a global problem. It also makes a point that this antimicrobial resistance is not only a scientific interesting issue, it has indeed negative effect on patient outcomes and also on health expenditure, because the second-line treatment are always more expensive than the first-line treatment. The third one is that we are running out of treatment options for some of the common infection, and this is a real problem. And finally, the report demonstrates the magnitude of the AMR, as well as shown also by Jeremy, the fact that some countries were completely white in the map shows that in some countries we have absolutely no idea or no data on what's happening. So the global action plan has the guiding principles of a global action plan are as follows. This is about the whole of society engagement. This is not only about government. This is about community. This is about individual people. This is about businesses. It's a whole of society. All the action needs to be based on the best available knowledge and evidence. We should put prevention first. So why? Well, because first it works better. It's better to avoid a problem than to have to deal with a problem later. And the other reason is it's vastly less costly. It should be the antibodies, the antimicrobial should be available to all countries, but this is in order to increase access. And indeed, people should not have been denied access to antimicrobials because they are poor or because they live in rural area. It should be an access for all, but at the same time, access must be clearly restricted. There are huge issues of sustainability, and this is due to practices in particular, but not only practices in other sectors, like in animal husbandry, as I say, in agriculture. So for a question of food security, you will all agree that it is important that the efficiency of agricultural practices remains to a high level. It is important to have food to feed the planet. But at the same time, it is important also that this legitimate thrive to more food doesn't have adverse effect on health. And also the other guiding principle is that there should be incremental target for implementation, because again there are different capacities and different priorities in the member states. In terms of strategic objectives, the Global Action Plan for Antimicrobial Resistance has 5 strategic objectives. The one is about knowledge again. It is about improving awareness and understanding of AMR through communication, education, training. If people are not convinced that this is a problem, it will not be tackled. The second is to strengthen the knowledge and evidence base through research, surveillance. The third is to reduce the incidence of infection through effective hygiene and infection prevention measures, the emphasis being on prevention. The fourth is to optimize the use of antimicrobial medicines in both human and animal health. And finally, is to develop a new business case for investment in making new medicine, new antimicrobials, vaccines and intervention. As you will see, this is something where the global research and development community for health products has failed in the last decade. So the reason why the strategy objective 3 to 5 are put in red is because these are ones that I will describe in some more detail in the rest of my talk. So first one, infection prevention and control. So we all know, by way talking about Ebola, everybody's talking about Ebola these days, that infection prevention and control is one of the main elements why we have so much transmission of Ebola in West Africa. And it is therefore important to develop infection prevention and control in general for the treatment of infectious diseases, but also in particular to avoid the spread of antimicrobial resistance. We know some best practices that can contribute to reducing antimicrobial resistance transmission, and some of these interventions are very, very simple. The first one is hand washing, hand hygiene. WHO has made a few years ago, was it 10 years ago or something, the first campaign on hand washing. Clean care is safe care, and this is about simple procedure to wash and avoid transmitted diseases. But there are also, of course, besides these very simple prevention methods, which are not always followed, I must say, in particular in hospital setting, there are also more complex means of intervention, and certainly these are needed for some of these microorganisms. But however, although it is now 10 years after we launched this campaign on hand hygiene, there are still many countries and settings which are struggling to establish infection prevention and control programs, as we have seen in West Africa, and also the infrastructure which is needed to put in practice all these best uses and best practices methods at the point of care. But clearly, this is not only a problem, I mentioned West Africa, but this is not only a problem for poor countries, it is also a problem for high-income countries, where in many parts of hospitals and other parts of the health sector, still implementation of these measures for infection prevention control is still not at the level where it should be. So what can we do in terms of doing things a bit differently? Can there be any innovation? Can we have also an R&D perspective in the infection prevention and control world? It is not only, and everybody will say, hand washing, this is just old-fashioned. My grandmother told me, go and wash your hands before you come to lunch. So is there anything new? So yes, of course, there are things which are new, although we should never forget the old recipes. But what is important also is that we all understand that some of the innovative approaches that would contribute to the reduction of antimicrobial resistance is about changing of behavior. And that's the changing of behavior of frontline staff, but also changing of behavior of whole society. They are new approaches, and they are developed even further to foster and to encourage patient participation in encouraging infection prevention and control practices from the community to the healthcare setting. We have a network of patient safety advocates. So these are usually people who have had, either for themselves or for one of their people of their family, have had adverse in healthcare settings. Somebody dying from either an infection or another event related to patient safety. And they are best advocates when they go to hospital or to the physician. Some of them are helping the community and awareness in the country to go to when they go to the healthcare setting to say, doctor, have you washed your hands? Doctor, by the way, this is the new syringe. And we need to have a community engagement. This is not because of the healthcare workers, because the doctors know This will happen because the patients know, because the community knows, and it is the community who must request from the healthcare sector that measures for infection prevention and control be effectively implemented. So this is new. This is new, and this is new because empowering patients, empowering the community was not that much a discourse a few decades ago. But there are also other human factors that should be including in engineering expertise in designing a better system for preventing AMR transmission in healthcare settings. This is about design. This is about making sure that when you have somewhere a place where the doctors can wash their hands, but it is not in the corner somewhere in the hospital that you have to walk for 1 minute to find water and then you get no soap. So this is something about the design of a healthcare setting to making sure that it is easy for the healthcare providers to do what they need to do. And of course, there is a lot of need for research to understand what works and what doesn't work, and to improve even further the infection prevention methodology in healthcare settings and beyond. The second area that we are very actively pursuing in terms of combating antimicrobial resistance is promoting effective use of medicines. You can see, we don't need to see all the names of the country. They are quite small, but you can see that there's a wide variety of antibiotic consumption in Europe, and these are data for 2011. If you compare, this is by Manhattan, and this is only Europe. You can see that in some countries, is it Turkey, here the largest, it seems to be, that you have a very large consumption of antibiotics as compared to the Netherlands, and this is about different policies. So the variability, some of the issues identified is this variability in levels of use. You can see Armenia is the highest. Turkey is the highest, and this has now stimulated intervention towards more rational use. But you can see in some countries like the Netherlands, you have a low use, which is due to policy choices, because in the country there is an advertisement and the policy makers are fighting antimicrobial resistance. But you see also in some countries in Europe, for example, in Armenia, this is where you have a low use of antibiotics, and this is not because they have the right policies. This is where you see you have a problem of access. So you can see again the two faces of coin. You have at the same time to promote appropriate access, because you can't allow to have underuse because of poor availability, but you need also to combat excess, because this drives antimicrobial resistance. Other issues identified in the area of medicines and rational use of antibiotics is the lack of information system. We don't know actually how much is used. What we know is how much is sold. And we don't know this all the time, but we have better data on the sales than on the use. But this, of course, we are lucky in the sense that indeed, because if we have data on sales, it will also include antibiotics which are procured without a prescription. So this is the third problem that we have in terms of issues identified, is that self-medication is common. And although antibiotics are prescription drugs, which is in principle it should be prescribed by a health professional, well, more than 50% of antibiotics currently are sold over the counter in many countries. So the choices of countries in terms of antibiotic use vary also a lot, and this is the fourth challenge that we have in the area of medicines. But in many countries there is an underuse of first-line treatment because they are felt to be not effective anymore, and some doctors may jump immediately to second-line use instead of going first with first-line. And then in particular, an overuse of some of the combinations like here, which makes it quite difficult to find antimicrobial resistance in these countries. So, how can we achieve better use of antibiotics? The first important factor is political commitment. There is a need for high-level political commitment interstructural involvement and coordination. This is a question of policy at the top level, as we can see in some of the European countries right now, and then it's a question of coordination between the health sector, the animal health, and agriculture. We need also to have better and reliable data on the use for policy guidance and also of knowledge of what are the best practices and what works in terms of best practices. Therefore, there needs to be action at different levels. This is about national policy, but also at level of a facility. It's not only about the decision makers in the government, it's also about what the choices of the individual physicians who are making prescription of antibiotics. There is a need to build partnership, of course, and this is a true multi-sectorial approach that we need to take if we want this to be successful. Mentioned already by Jeremy is the question of quality of the antimicrobial agents. So, as you know, we have been working in WHO for a number of years on an agenda item which has a very strange name, SSFFC, which is the Substandard Counterfeit Medicines Agenda. And antibiotics and antimicrobials in general are an excellent target for all the criminals who forge medicine. In particular, here you can see an example here. We have had reports, but we have had many reports like that, but in particular, reports of a fake antimalarial drug, Coartem, without active ingredient. So this is really, as you know, criminal activity. But there is also issue about quality that is not about criminal activities, but which is about just bad practices that needs to be reinforced in member states. So one of the activities that we should do, and we are very much involved in that also, is the strengthening of medicines regulatory authorities. They are the ones who can control whether the quality of antibiotics which are made or imported in the country is good. We need also to have more work to enforce the regulations related to the registration, the production, the distribution, enhance the national laboratory capacity for quality control. We need also to help countries eliminate the irrational prescription and irrational antibiotic combination, irrational pack sizes. If you have too many pills or not enough, and then people need to buy multiple boxes, or if in one box you have much more than what you need for one treatment, then this is also promoting more use of antibiotics. And as already mentioned, we need to organize campaign because we need to bring the public at large with us in the fight against antimicrobial resistance. This seems to be picking up in some countries. And Dame Sally Davis, who is the champion, of course, in the UK for antimicrobial resistance, told me the other day that she was in a taxi, and the taxi, she was coughing. And the taxi said, oh, maybe you should go and see the doctor. And she said, well, maybe. And then the taxi driver told her, but you should tell him no antibiotics. So if a London taxi driver starts to understand that if you have a cough, you not always need to get antibiotics, we are writing in the good path. So now the last element that I would like to give you some ideas of is about the development of new health technologies. And I will go through three elements: the building of a global R&D observatory and the fact that it should cover and will cover discovery and development for new antimicrobials, the models that we try to promote for the development, discovery and development of new antimicrobials, and finally the work which is being done in diagnostics. So you can see, and this is really a cause of worry, is that if you see the time scale and you can see the different decades, and you can see how much new antibiotics and classes of antibiotics have been discovered since the end of the 1970s. You can see that there was a time where we could be hopeful. that antimicrobial resistance would never become a problem, because as these antibiotics were used and abused and of no use anymore, there were new ones which were discovered. And it was a hope that the pipeline would again be renewed over time. But you can see that since that time, there has been only very few new drugs which have been discovered, and this gives a lot of anxiety that maybe the pipeline of what could become effective antibiotics is just drying out. So what will we be doing if the old ones are not of any use and we can't make new ones? So there is a need to better track what is happening in the area of development, discovery and development of antibiotics and antimicrobials in general. And last year, the member states has asked us that the Global Health R&D Observatory that we have to develop for another agenda item which is of interest to member states should indeed include all the information about research and development for antimicrobials. So what will we be able to do when we have the data on this in the R&D Observatory? This, of course, will allow the global community and in particular the research community to see what is the financing which is made available by member states and others in the discovery of new antimicrobials. This will help also prioritize the agenda, both at national, regional and global levels. It will allow also to have a better benchmarking of the investment which is made in the different countries in tackling this problem, and it will allow also to monitor and to evaluate the trends in the discovery and the development of new antimicrobials. And finally, we hope that it will be instrumental in facilitating coordination. So this is a tool that should be available and starts to be put in place in the months to come. So what we do, will we reinvent? How will we be able to get all the information that we will then put in the R&D Observatory for the consumption of all the member states and also of the research community at large? Of course not. It is meant that the Global R&D Observatory will draw on many sources. It will draw on regional observatory. It will draw on what we know from the international clinical trials registry platform, because of course new antimicrobials need to be tested in humans. So as soon as there is a new clinical trial which is registered, then it would come directly into the information thereof would come directly into the observatory. We need also to find information from publication, academical publication, and directly from the industry, because they are investing quite a lot of resources in this problem, in tackling this problem. Now, talking about business models, let me show you what's happening now in the world when you invest into making new antibiotics. So you have currently, this is the current situation right now, but was also the same situation in the past. You have big investment. So you have big investment by, for example, the US government or by the European Commission and other investment. And usually this is of the order of 700 million per project. For example, we have a project which is financed by the European Commission, which goes to the an initiative which is called the Innovative Medicines, the Innovative Medicines Initiative, and is providing money for the development of antimicrobials. So this money is either going through here for European money or going directly into R&D companies, into bioventure, small and large company, and all this generates intellectual property. So the intellectual property belongs to a company A, and the company A uses this intellectual property to produce antibiotics in the future. So the antibiotics go on the market, and because there is irrational use of antibiotics, and also because the industry, although they have had subsidies from the governments, they have still invested a lot of their own resources, they need to recoup their investment, of course, so they will try to sell as much as possible. Therefore, there will be excess of use, abuse, and these antibiotics will just fall out of utility. But another issue that we have is that this company A can very well sub-license this IP rights to the agro-business, and there this can also be made into antibiotics for animals, either for food complement or to treat animal illnesses, and again this will generate excess of use of these antibiotics, which will, after a number of years, not be useful anymore. So what have we proposed, what have we promoted since a little bit more than a year? We had proposed that there should be one or more initiative that would at the same time try to preserve the future antibiotics as well as giving incentive for their discovery. So it is of no use to promote innovation if you don't care about what's happening in preservation, because you just put the money in something which will not remain. So all the money which is invested, and we are really convinced about that, the money which is invested into discovery and development should have already in mind how these new antimicrobials will be preserved. So we had come with a notion that it could be a global initiative, that you would have using all the innovative financing of research and development, which have been proposed by many expert groups, in particular by the consultative expert working group on R&D financing and coordination, which is to work through prizes and grants to incentivize academics and biotechs, who are really the places where innovation is taking place. Then the development would be paid directly and completely by the same initiative, and this would happen in biotech company or with R&D, the big R&D pharmaceutical company. The company would do what they know they do very well, which is to register, to test and register the product. This could be done both by the research industry or by generic manufacturers, because the consortium would own the data which had been generated by academics and biotechs as well as the small industry. The intellectual property would be preserved so that there would be no further licenses given to any other party. And finally, the companies would be asked to produce the number of doses that are needed for the global community, and they would not be asked to sell the product. The product would be managed, that would be a managed use of a product, managed market, that would be, and the antibiotics would be, or antimicrobials would be provided according to needs to the different country. So is this possible? Well, it's different from the current model, because this is a model that would not use the market as an incentive. There would be the need, therefore, for no advertisement, and there would be the use of these antimicrobials will be limited. Would the industry agree to that model, where we know that some of the very large pharma have said that they understand that their model does not allow them to preserve the antibiotics? They cannot. They have a model, a business model, by which the more they sell, the better off they are. And therefore, and this is counterproductive for antimicrobials. So some of these big industry have said that provided their cost and cost plus are fully covered by the public sector, they would agree to produce enough and no more than what is needed in order to treat infectious disease with these new antibiotics. So this is something which is, of course, under discussion, because it is not the majority of the main model for research and development currently. We have also activities in the area of diagnostics, of course, because, as you know, it is very important, because as Jeremy has shown you in the ward it's not in the ward, it's for your patient in Vietnam. He has fever. You don't know. You need to treat the person. So you treat the patient with some empirism about what could work, and then you go one and one and until you find something which works. So it is important to be able to have point of care diagnostic, which are allows you to detect antimicrobial susceptibility. So we are not completely there yet. We have had a consultation in Geneva in April, but the technology is rapidly progressing. The idea is to have a point-of-care diagnostic which could allow within no more than 1 or 2 hours to have not only a diagnostic of what is the infectious agent, but also of what is the susceptibility to antimicrobials. And it is important that this diagnostic is done in a short period of time, because in many settings, if you let the patient go, then you can't find him or her anymore. So you need, when the patient is with you, to be able to do the diagnostic properly. So finally, just the last slide, we are working with some member states towards the development of a new initiative to support the development and rational use of new antibiotics. So this is very much in the line of what I described to you 2 slides ago on the idea of this consortium of public sector entities that would control the discovery, development, and use of antibiotics. And this will discuss the potential establishment of a product development partnership, which, in collaboration with public and private partners, would be able to develop new antimicrobials and ensure at the same time their rational use and their academic presentation and their preservation globally. So this is a consultation which will take place next week. It will be hosted by DNDi, and we hope that we will be able to come with a model that can be then presented and discussed with member states and with potential funders about how this kind of initiative could use another model, a model which is not based on the market, to develop important product for global public health. Thank you very much.
Thank you very much, Dr. Kieny, for the overview of what WHO is doing and intends to do for this issue. This is very informative. Now, the last but not the least speaker for today is Professor Christoph Gradmann, and he is from University of Oslo, professor in the Department of Community Medicine, and his research mainly focuses on the history of infectious diseases in modernity, 19th century to the present time. Recently, he has broadened his focus and now investigates what had happened to infectious diseases when they seem to be returning at the end of the 20th century. I'm sure that would be very interesting and having this perspective. So I would like to welcome Professor Gradmann, and just want to say that this session is actually broadcast on the internet, so I'm sure we have people registering possibly. So I want also to ask them to wait a little bit so that they can pose their questions and comments to the speakers. So, Professor.
Thank you for the very kind introduction, and I would also say that I'm quite thankful to be able to talk here about the history of antibiotics resistance and to present some work that was done by other scholars and myself. Now, when we talk about antibiotics resistance, and this has been mentioned in the room already, it is very often presented as a recent threat, as if everybody yesterday woke up to the fact, oh my goodness, there's an empty pipeline, what can we do about it? In fact, I would like to, in my presentation today, like to counter that impression of antibiotic resistance as something that is something that we recently woke up to. In fact, it has a long history. Neither knowledge nor awareness of the problems of antimicrobial resistance are new. However, insight that was gained in earlier decades was rarely acted upon. And in that sense, I could hardly agree more with what has been said earlier by the Director General, that people never learn. So my story will sadly be a story of opportunities lost, actually, in the history of antimicrobial resistance. I'm going to take you through a few episodes in that history, and that is going to be the emergence of the phenomenon during World War II. We're going to talk about how can we understand overprescription of antibiotics in relation to respiratory tract infections, and we're going to visit the 1950s for that purpose. we're going to take a look at how antimicrobial resistance changed the modern hospital and how that resulted in a major crisis in hospital medicine in the 50s and 60s. We're looking at the 1960s, at a decade when management of antibiotics and tackling antimicrobial resistance was really at the crossroads. This is a very interesting decade. Finally, we're going to have a look at the question, where does the empty pipeline actually come from? How did it begin to run empty? Coming to my first story, when we talk about the history of antimicrobial resistance, we shouldn't start with penicillin and the antibiotics. We should actually start with the sulfur drugs, who came a couple of years earlier, and you see a couple of preparations of the first sulfur drug, frontosil, on the upper left. They were introduced from 1935 into World War II, being the product of a huge chemical industry. Very quickly, there was a large number of effective drugs. And if we try to understand how did this affect the therapy of infections that could be targeted with that, we have to be aware that there's two things happening. And one is always highlighted, which is that that efficacy was good. These were effective drugs. They could actually treat people. Now there's also another thing, and that is very important in the history of antimicrobial resistance. They would add, and they would be advertised as tools that would also raise efficiency in handling patients. Like you could subject them to more standardized treatments, treatment would be shorter. That's something that happens when sulfur drugs are introduced in masses in World War II. Treatment becomes standardized, short, in other words, more efficient. And the mass application of these medicines in World War II results in that a laboratory phenomenon, something that geneticists and pharmacologists have been studying for decades, which is resistant strains of microbes. It was an odd phenomenon, but it had been known for decades. Suddenly it turns into a mass phenomenon. And as you can see from the quote from a prominent American microbiologist, William Kirby, it was in relation to treating gonorrhea, actually, during World War II, that antimicrobial resistance first appeared on stage to a larger extent. And fungal antibiotics were actually taken into use as a replacement of sulfonamides in the Northern African war theater because there was too much resistant gonorrhea. So you had to replace the sulfonamide resistance, you have to tackle it, and you did it by bringing in penicillin. So that's how resistance became a phenomenon of clinical relevance, and I want to remind you of the fact that there's this efficiency argument which will take us through the whole of the history, which is in many ways something that I think we need to tackle if you want to have more and better use of antibiotics. So let's move on, and let's move into the 1950s. So antibiotics have entered the market, actually. And in the 1950s, several interesting things happened that result in a grandiose proliferation of the type of medicine. We have to remember that when it was introduced towards the end of the war, it was a medicine that would only be used in severe cases. And initially it was scarce, but it went to being all over the place in a very short time. In the 1950s, several interesting things happened. It went from syringe to pill. So it could now be much easier to be applied in general practice. Antibiotics went from narrow to broad spectrum. So penicillin, the other antibiotics entered the market. You get tetracyclines, you get all kinds of medicines that had a broader spectrum, and they would be advertised in that way. So you don't need to bother with a too precise diagnosis. You can employ them in treatment, and they will most likely going to work. So again, we see the efficiency argument paving the way of antibiotics into all kinds of applications. The same can be said for the proliferation of fixed dose combinations that were becoming very popular in these days. And generally spoken, antibiotics change target in those years. They go from being medicines that were used in handling severe cases to managing outcomes. And we can see that, and that's what the quote on the right-hand side relates to in how bronchitis is suddenly approached. When antibiotics are put on the market, penicillin would be given to people with pneumonia if they would have been in a serious state. in the 1950s, we get to an argument and say, you know, we don't want to see this developing. We can actually save the doctor's time, and we can also reduce the risk on the side of the patient. We can, in other words, make things more efficient if we give the patient antibiotics before pneumonia arises. And that, we can probably all agree that to a certain extent that's rational, but it also paves the way for mass proliferation of that medicine. And bronchitis, that normally would have been not much bothered about in terms of treatment, suddenly becomes a condition that is routinely addressed with antibiotics. Another thing that we also need to know about the 1950s, and I'm just rounding up here, is that in the 1950s, it's that antibiotics in large scale enter farming. So first from infection control, but later on as growth enhancers. And you can see that little aureomycin advert on the right-hand side pointing us to the instance that it's in this decade, actually, that the market in animal husbandry turns out to be much bigger than the market in human medicine. But what we most of all need to remember is that we have a proliferation and antibiotics get used in much milder conditions. And they're now in general practice, not just in hospital medicine. What's the result of this? Well, the result of this is a massive crisis of antibiotic resistance that we can pinpoint into the 1950s. In the 1940s, patients who would be diagnosed with a resistant strain would be considered individual cases. If resistance arose in a patient, it would be a treatment failure in the individual patient, and it could be approached by switching to a different antibiotic. From 1953 on, there was a pandemic of resistant staphylococcus. It's by that time a PRSA, not an MRSA as today, so it's a penicillin-resistant staphylococcus. It could be determined by a diagnostic with phages. That's why it's called Staph 8081. And that thing spread around the globe from 1953 on. The interesting thing is here that it turned out to be not the result, but the product of the application of antibiotics in hospitals. And as Lobury said, the problem of hospital infections had been complicated rather than solved by antibiotics. Giving patients antibiotics in hospitals knocks out certain strains and selects other bacteria which would then infect the patient. And then the patients, often via the health personnel, would cross-infect each other. And this was documented in the 1950s, studying Staph 8081 on the example of maternity wards around the globe where moms would suffer from mastitis, and these staphylococcal infections would be the basis of that. On the scientific side, this results in a new specialty being created inside hospital medicine, which is clinical microbiology. So suddenly, knowledge that was in basic science about antimicrobial resistance becomes a medical science and is established in many places. However, it also results, and that's probably more important for our history today, it results in the notion of the hospital changing. Hospitals had, for most of the 20th century, been harbingers of therapeutic progress. Whichever modern medicine you had, it would be tried and applied in a hospital setting. The hospital was a safe and modern environment. Towards the end of the 1950s, it was dawning to hospital physicians that the hospital had become the most dangerous place it could possibly be. So people who went to a hospital for entirely unrelated reasons got infected by Staph 8081 in those very places. Antibiotic resistance became part of environmental challenges that we find in hospitals. And that's what the last quote and the little picture is about. This is a study that an American pathologist did in 1959, and he was studying some people dying from infection in a hospital. Where did they get that infection from? Did it happen outside or inside the hospital? And he was comparing data from the pre-antibiotic age to 1958. And it turns out that before World War II, people who would die from an infection in the hospital had come to the hospital with that infection. Now, they usually got the infection inside the hospital. So the hospital, as a result of antibiotics mass application, had turned to be an extremely dangerous environment. So clearly, by the end of the 1950s, the problematic aspects of antibiotics application and antimicrobial resistance had become visible, and it was clear this was not a problem of individual patients, but something that needed to be addressed on large scale. What do we do about it? So we move on to the 1960s, and we move on to something that's called therapeutic rationalism. There was a movement, I would say, in clinical medicine, clinical microbiology, to say, okay, we have to restrain and make more rational our use of antibiotics. They have to be played, you have to have a proper diagnosis and all that. I think you know everything that's associated with that. And I want to explain, and that became a wide movement and would argue for restraint in use of antibiotics. And I want to approach that for you through a little story of a WHO-sponsored initiative to create standards for sensitivity testing, because that thing didn't exist before, actually. But you need standards for sensitivity testing to adjust your therapy to the patient. You need to know what the minimal inhibitory concentration is. You also need that enabled to do epidemiology in the first place, which was simply not possible before that time. And on the picture, you see this group, which was called the International Collaborative Study, run by an American and a Swedish scientist, Hans Eriksson and John Cheris, sponsored by WHO, and they tried to develop, they tried to make the thing, what you see on the above picture this year, where's this thing? The DISC test, a lot more precise. And so they were trying to refine sensitivity testing, they were trying to develop diagnostic standards, and this had a double aim of facilitating epidemiology and restraining the application of antibiotics. So the idea that the more, the better is not a good idea. As you can see in the quote at the lower, below on the slide by Ernest Javits, that they were trying to fight that type of mentality, that the more antibiotics you give, the better that would be. In fact, they were instead trying to approach antibiotics from the public health agenda and say, we have to guard, we have to rationally use that type of medicine so we will have a longer use of it. The question is, did all that happen? And it didn't. And here's my next slide. And it's about methicillin. That would be another answer to stuff 8081, so to say. So instead, because there's always several interests at work in history, and what we also see in the 1960s is that the change of the epidemiology of infectious disease that had resulted from the application of antibiotics was something that could be embraced as a growth market or in pharmaceutical development. So companies were now trying to develop medicines to the new infections, antibiotics that would tackle resistant bacteria, for example, that would specifically address nosocomial infections, which were becoming very widespread, and all that. So the answer to stuff 8081 became not restrained in the use of antibiotics, but it became a second wave of antibiotic development, actually. The 1960s is a decade when many companies start or expand large-scale screening programs, and they're trying to develop, and mostly successfully, second-generation antibiotics, and they target the problems created by the first generation as a growth market. The quote is just taken from the Celibanin advert. It was marketed as Celibanin as Beecham development. And you can see also the quote from the article where the medicine was presented in the Lancet. And it is specifically sold, advertised as a medicine that will rid your hospital of the staphylococcal challenges. One thing that there's a lesson in there for us, which is that in the 1960s, while the idea of rational management of antibiotics did exist, nobody thought about empty pipelines yet. The pipeline was full for everyone. So the answer to a crisis could be just, okay, let's throw more money at the thing. Let's do more innovation, and then we're going to have more medicines. The idea of an empty pipeline only came in later. Problems of antibiotics application were studied in the 1950s and 60s, but people did so without the notion of an empty pipeline. So when did the atmosphere become more gloomy? That's a difficult thing to say, but I would say that this happened around 1970. And I would like to pin it to one particular thing that happened. And it's the discovery of the transfer of resistance factors between different species of bacteria that, for the medical and also the wider public, put antimicrobial resistance on the map. So it was this transfer of resistance factors between different species was already discovered in the late 1950s, but it gained some notoriety through the work of a British microbiologist, E.S. Anderson, on Salmonella typhimurium from 1965. And it's here that the idea comes up, oh my goodness, a resistant strain is no longer a resistant strain, but the problem can actually jump from one species to another. And that's when the notion of a possible return to the pre-antibiotic dark ages, as the New England Journal of Medicine put it, in response to that type of discovery, that's when this notion actually became popular. So we see that in the late 1960s, and it was not clear how widespread that phenomenon of the transfer of resistant genes would actually be. People initially thought it was a slightly bigger importance than we tend to think today. So it was a wake-up call, absolutely. It also linked agrarian overuse and human medicine, because now you could think about resistance factors going from one to the other, actually. And that's why I'm giving you a quote here from Bernard Dixon's classic article, Antibiotics on the Farm, from 1967, where he says the misuse of antibiotics in husbandry is something that is a challenge not just for husbandry, it's actually a challenge for society at large. Still, in those years, drug development is going on at a high pace. So the next question we need to ask is, how on earth did the pipeline run dry? And that's what my next slide is about. And I think this is about two things. First, it's a story about vanishing targets. We have to be aware that when antibiotics and sulfur drugs were developed, they would be targeted against conditions that have been identified by medicine much earlier on, the so-called common infectious diseases, things like tuberculosis and typhoid and whatnot. And these disappear. And developing medicines for such conditions doesn't seem to be a very good idea. It doesn't seem to be very profitable anymore. And I've been working in the archives of one big pharmaceutical company, because that's one of the few companies that actually opens their archives. Not like this company is any worse than anybody else or any better. It's just they have an open archive. And you see here in the quote that what they do in the 1970s is that they say there may be problems with TB, and there may be people who still need modern TB medicines, but these are not the people who can afford our products. So we're going to take our money elsewhere, and we're going to develop medicines. And again, we're thinking of the pathologies created by first and second generation antibiotics. And that's why I'm giving you so it's envisioning smaller markets in high income countries, and the nice quote from an advert for ciprofloxacin tells us that. So this was marketed as a medicine that would specifically target resistant bacteria. And if you would read other adverts, actually, we still find the efficiency language very much at work. So your clinical ward is a mess, we give you the medicine to make it work. So that's one thing about de-emptying pipelines and dropping things that were not profitable. Another thing is that, and that seems to be the case, that the screening programs, which had been scaled up in the 1960s in particular, didn't seem to be a profitable way of developing antibiotics. In many of the big drug developing companies in the 1970s, there was a disillusionment about the amount of money invested into screening and the small outcome of effective molecules from that type of program. And what you see here is a small excerpt from a high-profile meeting in the company Bayer in 1980, where they said, okay, it seems like we're seeing the end of the road when it comes to antibiotics. Chemotherapy, which is for them antibiotics and sulfonamides, and said, we have the innovative potential is low because we've seen almost everything that can come out of that pipeline, while we need totally new approaches, and these never materialize, and by the quotation marks, that the the person who wrote this used, you can also see that he was quite skeptical what this was going to be about. But the main thing is that people were beginning to lose faith in antibiotic therapy and said, probably the pipeline is not empty, but there's going to be, it's a deadlock actually. There's not going to be a lot more medicine. And all this type of disillusionment and the previous histories then fired off in a situation of widely recognized crisis around the year 1990. What you see on the left-hand side is one of the more famous covers of Science from August 1992, and it's a typical early 1990s dystopia, which combines emerging diseases, HIV, environmental disasters, and whatever you can put into that. This was very much the atmosphere of the days. And antimicrobial resistance becomes part of that big environmental crisis that is discussed and felt in the years after the collapse, at the end of the Cold War around the world. So HIV, emerging infections, environmental dystopias become one. And if we had more time, we could go into that on the example of MDR-TB, which was the one example where all this was discussed about, actually. And now the notion of the post-antibiotic age actually becomes very, very prevalent. And I'm quoting here Stuart Levy because he wrote a book in the early 1990s that became an eye-opener for many about that particular issue. However, what's also important is that and this is why this is my last slide about the history, is that we've pretty much stuck with that notion ever since. So we've had this idea that we are approaching a post-microbial, antimicrobial era, written by the editor of Science in 1992. And if you read the CDC statement from 2013, it's almost the same. So we're sitting with this bleak picture, and the question is, did it help us to go anywhere? And I would say yes. It's been a perpetual, but it has been a productive crisis, because many of the dreams of the therapeutic rationalists from the 1960s now experience a belated kind of justification. To give you an example, the idea of a global surveillance of antimicrobial resistance that was part and parcel of the study of the 1960s that I've spoken about, but couldn't be put into practice for lack of funds, was finally endorsed in the late 1980s, and that's what became WHONET. And the people who run WHONET were actually trained in the laboratories of the 1960s therapeutic rationalists. So I would say it's a perpetual crisis, but much of what we have today in terms of documentation, surveillance, and so on, is a result of that crisis. So I thought it was a good thing to have it. Let me come to my conclusion. Is there lessons from history? And I would like to give you a personal approach here. What you see on that slide is something that I got to read after having become an immigrant, moving from Germany to Norway in the late 2000s, actually. And it shows on the very left-hand side Norway, and this is about which antibiotics are used in general practice. And it shows you that Norway is the country where an enormous amount of very outdated antibiotics are used. There's lots of original penicillin. And what it also shows you that this varies a lot in Europe, and we've seen slides to documenting the same earlier on. And I said to myself as a historian, wait, there's a history in here. Maybe this is related. So the point that the authors of this paper were making, that restraining use, staying with the old antibiotics, is something that can actually lower antimicrobial resistance, probably that has a history. So we started to work on that, and we came up with the fact that these consumption patterns, let's put it like that, they are dependent on cultural and social factors, and they are remarkably stable over a long time. That doesn't mean they cannot be changed, but it opens an alley for a very productive dialogue between public health, clinical medicine, and medical historians. And so I started to do work together with people who work on antibiotic application in general healthcare. And it was some of the most interesting work I've done. To come to a more general conclusion, the history we've seen is a history of events. So we've seen new antibiotics being developed, we see antimicrobial resistance appearing on stage, but it's also a history of non-events, things not happening. So we've seen advice being developed from the 1960s on, and it was never acted upon. Or we're seeing industries basically losing interest in the class of medicines, and I think you've given us some insight in how we're trying to awake their interest in that, and it's not for me as a historian to judge whether or not this is supposed to work. But if I would like to say one thing as a historian, it's that you never really know what happens next. But looking at the empty pipeline is probably not going to solve the problem. It would be very nice to have some medicines in there, but looking at the history of antimicrobial resistance teaches us that there's lots of good ideas that have hardly been taken into practice. And if we want to tackle the problem, it's probably that what we should act upon. Thanks for listening.
Thank you very much, Professor, for this historical perspective and the lessons. Now, we are in the last part, actually, of the seminar, and we have only like 12 minutes. But I would like to hand this part over to Professor Sanjoy Pattarashia, who is the Director of the Center for Global Health Histories and Professor of Health History of Medicine in York University. And Sanjoy has been a great supporter and driver, actually, for the Global Health History seminars in collaboration with Wellcome Trust. And now York is a collaborating center, actually, for Global Health History. So, Sanjoy, you take over for the discussion and comments. And the tradition is to give floor first to the member states who are represented here, and then to our guests and staff. And we have some people on the webinar. Sanjoy.
Thank you, Najib. If I could just request people to identify themselves when they ask their questions or make their comments, because there are people on the internet, and I'm sure they would like to know who you are. So can I throw the floor open for questions, comments from the national missions first, perhaps? Madam.
Thank you very much, and good afternoon, everyone. My name is Anna Hallén. I'm based at the Swedish mission here in Geneva. I'm working as the health attaché. And I just wanted to start by thanking the organizers for arranging this seminar and for all the very good presentations, including the very interesting historical background given. And we would very much welcome to have the slides if possible. And Sweden couldn't agree more to the need that was mentioned to seize the moment that we see right now to move globally on AMR. And I believe this momentum is spurred in part by the very strong commitment that was shown, the support that was given to the resolution at most recent WHA to develop a global action plan, but also by the challenges that we have seen recently in health systems delivery and also building strong health systems. I'm very glad that the area of surveillance was mentioned. It is not, as was said, the sole solution to the problem, but it's definitely a fundamental sort of building block. We need solid data to develop and implement strategies to tackle AMR, and also to be able to assess the impact of measures taken. And Sweden has just hosted a high-level technical meeting on surveillance with the member states from all WHO regions, from the WHO as well, headquarters and regional offices, the academia and others. And when I say just, I mean just. The meeting closed about an hour ago, I believe. It took place yesterday and today. The aim of the meeting was to discuss various aspects of surveillance and the need for a global program for AMR surveillance. And one aspect that was discussed was the sharing of data and information so that national, regional, and global trends can be detected and monitored. An outcome statement was agreed upon, spelling out the need to build a common vision around and commitment to establishing a global program for surveillance of AMR in human health. From tomorrow on, there will be more information at the website of the Swedish mission here in Geneva if anyone is interested to have a closer look. And just to finish off by underlining, of course, WHO's central role in the global response to AMR and in supporting countries in their aim to mount national response. And the work that we have ahead of us, of course, will require continued engagement and adequate resources as well as political will from countries. We are, of course, doing this together. And from Sweden, we very much look forward to the discussions, the upcoming discussions on the draft global action plan at the EB, but also the program budget, of course, that will make space for action. Thank you.
Thank you. Further questions? Sir.
Thank you. I'm from Estonia. Estonia also was some years ago one of top countries in negative aspect in this AMR list. But in some recent years we have introduced also the comprehensive approach to healthcare, and hopefully we will be successful in some further analysis. But regarding your presentation, I have a question. Could it be that as the AMR research is developing, also the search for cure is developing, and we are moving towards different kind of laboratories from the chemistry laboratories to a nano and bio laboratories? And can you maybe comment? Do you see any future on gene level approach on tackling those diseases in the future? Thanks.
Well, of course, the method for diagnostics are changing a lot, and this is already at the level of genes. So there are several factors. One, in terms of determination of the pathogen itself, you can use genes, and the question of the resistance is a little bit more complicated because usually there are multiple factors that determine resistance. So you can't really have determined the probe to cover them all. So therefore, you have to work through a mixture of classical biology to see what kind of metabolism the bacterial, for example, produces, and be able to detect this also. So this is really very, I would say, new methods which are being developed, and we hope that in the coming years there will be tools in order to better inform the doctor or the health worker who will do the prescription. We hope that in the future it will be the case that then antibiotics and antimicrobial is only prescribed upon diagnostics of the organism, and more importantly of the sensitivity. But of course this is still for the timing science fiction, but it is evolving very quickly.
We have a question from the WHO Regional Office for Europe, from Niels Fettier, and he wonders what the panel would think about creating a financing instrument similar to the World Bank's green bonds, but for infection prevention. Would anyone like to tackle that question?
Yeah, I can. I'm not a financial expert, but clearly the method by which we look at how to better use existing drugs, like antibiotics, antivirals, antiparasitic, etc., and the way we may develop new ones has to change from the current model, because the current model clearly is not working, and Marie-Paule outlined one way of doing that. Such bonds as you've asked here, Niels, I think is another good example. I think the whole spectrum of the incentives, the disincentives, the link between sale volume and price has to be changed in order to ensure a healthy pipeline in the future. But critically, we also have to make sure we use better what we currently have, because even if we change that pipeline for the future, that future is not going to happen tomorrow, and there's going to be a time gap between where we are today and where any new incentives, financial methods of supporting this approach come to fruition. So better use of what we have today, as well as looking for the future, is critical to go together. But I would just say, on an optimistic note, that we can do this. We did this for HIV. We went from having no treatments and not even knowing what caused it within about a decade to having an incredible pipeline which changed the face of global health, actually, and the lives of many, many people. So it is achievable. And I think we cannot see this just as a problem for industry and commerce. It's got to be taken on through the public purse. And interestingly, I think there are other models in other sectors of society where we accept that is the role of the public purse. The military, for instance.
Yeah, I would just add to that. I very much support that. I mean, talking about antimicrobial resistance, you often think you're on a slippery slope, but you're actually not. So there's enough examples whereby by the application of certain rules and practices, processes can actually almost be reverted, where you can lower for example, the presence of certain strains in certain clinical wards by doing things differently. So while the history has been one of the slippery slope, there's no need for it to move on in that direction. It really depends on what we do.
Maybe I can try to take the question too. Well, one of the proposals that we had in the model that we had developed with many other experts is to create a public entities consortium that would look at the whole, the A to Z of antimicrobials. This is from the discovery, very early discovery, to the preservation, and try to have answers to map all the steps. So one of the steps in the area of discovery was to build on the natural products, because there is a lot, as you know, antimicrobials are coming from bark of exotic trees, for example. So there is still a lot to be gained in trying to see what are the natural products that exist in plants in tropical or subtropical area, and try to see what can be done. And this indeed needs to be done in partnership. There is no Nagoya Protocol, which preserves the right of a population on their natural resources, and this should really be done, this type of research, in full collaboration with developing country partners. So this is a way, and we know that they have less resources. So this is why, in terms of using the innovative financing instruments which were described by many experts, like the CWG, using prices and other financial instruments to incentivize those who are not the main players, which are usually the European or the US or the American in general, universities and small companies, to try to develop financial instruments that can be useful also for emergent or low-income countries, in order to tap on their resources. And these are natural resources as well as brain, because when you think that we have the potential that we have for bright scientists in China and India, we should certainly tap on them to have a great idea for the development of new antimicrobials. So what I have, in terms of pharmaceutical waste, I have not much to say on this. Any of the others?
I'm certainly no expert on pharmaceutical waste, but the very interesting question reminds me of one feature of the recent history of pharmaceutical industries, I think, that needs to be taken into account when one discusses strategies, which is that until about 20 years ago, pharmaceutical industries was basically only to be found in the global north. So whatever we were tackling was products produced in the global north and handled elsewhere. and that's and what has changed significantly is now there's pharmaceutical industries in all kinds of places, and the only thing I can probably say about the problem of pharmaceutical waste is it's very likely to be a much more severe problem in the very near future because of that growth of the pharmaceutical industry in the global south.
Comments? Questions? Leo?
Theo Grace with the WHO's Ebola R&D team and with the University of York Centre for Global Health Histories. So there was a talk in all three presentations about community engagement, and there was mention of the policy changes needed at the governmental level and of the way to engage with manufacturers to change the market approach. I was wondering about the role of organizations such as the Wellcome Trust and the WHO in this community engagement side, the third arm, and how you change the, say, prescribing habits of GPs, which I know in the UK has a tendency to prescribe, maybe with infections that actually could be treated by antibiotics, but at times where the antibiotics aren't going to have an impact, where this is common practice, how this kind of thing can change, and particularly how that can be adapted looking to new potential interventions, whether it's looking at new interventions like monoclonals or old potential interventions like bacteriophages and other things in the future to make sure we don't repeat mistakes.
I think you raise a critical point. Nobody can think that the solution to the issue we're facing is going to purely be a medical one. There is no doubt, whatever you mean by community engagement, greater understanding and greater appreciation of the value of this broad class of interventions is critical. And the truth is, we don't value this class anywhere near in the same way that we might value other classes of therapeutic or other interventions that we use. So yes, I think at every level, government level, public level, general practice, hospitals, that in fact within the hospital sector, the understanding of basic pharmacology is not today what it was 20 or 30 years ago. So I think it's a huge task, and we cannot think that we'll have a single bullet medical answer to this problem without ensuring that that's structured in a way that ensures it's part of the societal response, because ultimately those two things and many others are going to have to go together.
Hi, Jennifer Cole from Royal Life Services Institute. Really following up on that last point. In terms of the research that's done, we ran a workshop sponsored by the Science and Technology Facilities Council nearly 2 years ago now on identifying where the research gaps were in tackling AMR. And the outcome from that workshop was almost exclusively that where we needed more research was in those other non-medical intervention, looking at why are antibiotics so overused in hospitals, why are guidelines on reducing antibiotic use in hospitals not taken up, and specifically one of the ones we looked at was the NICE guidelines on antibiotics in neonatal care. The idea of that was it would feed into the Research Council's work on informing future research calls, and in particular the Cross-Research Council initiative from the Medical Research Council. Now, when those calls have come out, there are 4 phases, the first 1 or 2 of which are the purely medical interventions, the more rapid diagnosis, the feeding up the drugs pipeline that everybody knows is not the only answer, and yet some of the more innovative research projects that the community was crying out to be funded are down in phases 3 and 4 of that, with still no sign as to when those calls are actually going to go out. And I think certainly one thing we found from a combination of both the policy and the academic sectors is just absolute frustration at the research that the sector feels is what we really need to do to really understand the problem, constantly being pushed down the agenda, while the medical solutions that we know there's a problem with the pipeline, but we also know that if those new drugs come through the pipeline, poor management of them is going to lead to all the problems we've ever had, seems to still be at the top of the agenda. And I don't know if there's necessarily an answer to that, but I think it's one thing that we see increasingly as a frustration, both within actually the medical sector and the policy community.
Yeah, I mean, I'm not part of those research council calls, so I can't comment on those. But no, I absolutely share your frustration. There is not just. It's very nice to have a historical perspective on this. There is not just a single magic bullet medical answer, technological answer to the problem. And until we see that, and there isn't actually even just a human element answer to the problem, but as we've seen repeatedly through the calls, I mean, this includes all sectors. Economics and farming and agriculture and humans and society, and until we bring all of those together to address the issue, we're not going to solve it. I'm optimistic about where we could go in the future. One of the pessimistic areas I've got is what you're describing could well get worse in the future with the increasing fragmentation of our various elements across societies, fragmentation of health service, fragmentation of health delivery, fragmentation of health and society together. And I think until we bring those back together, it's difficult to think we're going to get a simple answer to this.
It's beyond 2, so is there a question? Okay, please. Last, yes.
Oh, there we go. I'll make it brief. My name is Finola Hackett. I'm with WHO Department of Public Health and Environment, and I'm doing some work on food security and agriculture and health impacts. And so I know that all the presentations touched on the importance, as you just mentioned, Dr. Farrar, of the animal side of things. So I was just wondering, perhaps more elaboration on WHO's engagement with FAO and other stakeholders to look at the role of livestock husbandry in the issue of AMR.
Yeah, there is a lot of work between the three organizations, FAO, IE, and WHO. We need to understand also where the different organizations come from. We need to recognize the need also for the global society to ensure food security. So this is something that needs to move and needs to be put in dialogue. It's not about pointing finger to say, it's because antibiotics are abused in the farming industry that we have a problem. We have a problem because of this and because of overuse in human medicine. So there is a dialogue which is a very positive dialogue and willing to move forward. It's only in this kind of dialogue that we can make progress.
Well, yes. I mean, on behalf of the WHO Global Health Histories Partnership, I'd like to thank the national missions for their time and for being here and for contributing. I'm deeply grateful to all WHO colleagues who've contributed their time and effort to make this possible. Amazing meeting to be part of. I must thank the Wellcome Trust, particularly Professor Jeremy Farrar, for coming over. I know how busy he is, but also the Wellcome Trust generally for supporting the Global Health Histories project since its inception in 2004. And I'd like to thank everyone who's been here, because we gain strength from you. Your participation is very important, online, but also physical. My colleague Christoph Gradmann from the University of Oslo, a great supporter of the GHH project. We're grateful to him. So long may this collaboration continue. And maybe Najib would like to say a few more words.
Thank you. Thank you very much. No, I just want to thank, of course, the Director General for being here, Professor Farrar, Dr. Marie-Paule Kieny. I know how busy you are. I know how busy everybody is. Professor Gradmann and Sanjoy, and special thanks, of course, to the missions for being here. Big thanks to the colleagues who have assisted in making this a reality and implementation, Lara, Jing, and Mariam, and everybody around the table, and the listeners on the web. And our commitment, our promise is to continue collaborating, working together to even improve and make the history more understandable, and hopefully we will learn something from history. Thank you very much all.